Okay, guys, so welcome to the pathophysiology of diabetes and obesity. And I should probably have this backward because the way this lecture will go is we're actually going to start with obesity. In each unit, we're going to cover the epidemiology, pathology, or pathophysiology, and then we'll get into some rehabilitation considerations for both obesity and diabetes. I felt it was kind of nice to combine these two into a lecture because they're, as you'll see, they're pretty intimately related in terms of pathological conditions. Now, it would be remiss, right, if we didn't touch on the Whip and Wasserman gas exchange gears, and remembering that this describes the dynamic interplay between the peripheral muscle, the skeletal muscle, peripheral skeletal muscle, the circulation, and ventilatory cogs, right? And anytime we have dysfunction along any of those cogs, it'll make one of the other ones work a little bit harder. Now, in this presentation, we're really be talking about impacts to really the periphery, which looking at obesity, which is going to affect the quality of the muscle, but it's also going to have, as you'll see, impacts on their circulatory system and in the in the pulmonary unit of this course, we'll get into how obesity affects breathing in particular. That's really my area of research, but we'll save that for a few weeks from now. So just some quick terms, obesity, is classified really according to our BMI. You can think of it as weight that's higher than what's considered a healthy weight given a particular height. Now, which is kind of how we quantify BMI. Now, this is for individuals over the age of 20. Pediatric patients, we use their growth percentile, and we'll show you that one in a second. So this is really for adults, and the reference standard by the CDC is age 20 or older. Now, as you can see, overweight would be anyone from a BMI of 25 to 30. Obesity is anyone above 30. You may see older terms utilized. You might have seen morbid obesity and different things like that. We don't really use those terms anymore. Those are kind of outdated and outmoded terms. We classify these either by class, so class 1 through 3, or moderate, severe, and very severe. But you'll more often see class 1 through 3 in clinical practice. Now, again, for people under 20 years old, we use the body mass index per age percentiles. This is what you would get when you were you go into your pediatrician's office. They would measure your height, measure your weight, and then plot that along a scale, and that corresponds to the percentiles of people at your height, at your age, and sometimes at your sex as well. So just seeing how you are distributing in terms of weight as you age. So you would see percentiles. Now, obesity is a growing concern. We're going to show some maps here from the CDC, which will plot over time every 4 years. If you look back in the early 90s, this really wasn't the same problem as we have today. And this is data from 2015, and now we have even more recent data from 2018. We're seeing that no state or territory has a prevalence of obesity less than 20%. That was unthinkable even 20, 30 years ago. And now we have several states, we've got 9 in fact, that have obesity greater than 35%, with Mississippi being the highest, I believe at a prevalence roughly about 40%. This is 2018 data. This changes every single year. As you guys are looking at this graph, you can see, well, this kind of looks very similar to other graphs, right? It looks similar to our graph for cardiovascular disease. It seems similar to our graph for diabetes. Again, these are often related. But it also looks similar to our graphs for disturbed sleep. It looks similar to our graphs for physical inactivity and other social forces. And we'll kind of get into that obesity and a lot of the other non-communicable diseases that we've seen in this country, there's more social forces at play than I think more people give credit for. But obviously, we do see, again, this just geographical distribution. And again, there's some highlights again. No state has a prevalence less than 20%. Colorado had held out for a long time, and Hawaii, but even they are above 20%. There's 17 states between 25 and 30% of the population. And this is obesity, not just overweight. There's a lot more overweight people as well. And again, 9 states over 35%. If you go back to 1994, this doesn't even register, right? I mean, they're very rare to have a state even above 15%, right? So it's definitely a big problem. Now, obesity again has a very if you factor in overweight as well, it affects a lot of people. Obesity alone affects close to about 40% of the U.S. adult population. Again, that's cutoff of age 20 or above. It's associated with a variety of chronic diseases. We'll talk about some of the bigger ones in later slides. But the prevalence of obesity and overweight, 71%. That's the vast majority of our population. What's especially concerning is we look at the prevalence in kids that continues to increase. 1 in 3 American kids and teenagers are overweight or obese. That's 33%. And we can see the breakdown by age prevalence. The concern with kids is, obese kids often become obese adults, right? So a lot of the chronic diseases that we're seeing associated with obesity, such as diabetes, hypertension, like we're seeing earlier, and we're seeing in potentially even greater amounts, in adulthood. So it's a pretty big problem that we're really starting now to see the downstream effects, right, of the obesity problem in kids, translating now to obese adults, and it's a costly issue, right? The direct and indirect cost of obesity and its associated comorbidities. We're talking about stroke. Talking about osteoarthritis. We'll get to some of them in a bit, and cardiovascular disease accounts for about $149 billion per year. It's 21% of annual medical costs in the United States, and that makes sense because a large proportion of people in the United States are obese, right? It would make sense that a lot of our spending goes towards managing it. What's maybe people don't realize is that the overall costs are higher. However, the per capita cost, so if we're treating an obese patient, costs 42% higher than it would be for a normal patient. There's unique needs, unique challenges, which raise the cost of managing that patient. It's 81% higher for those with class 2 obesity. So we look at medical spending, we look at our budget, our GDP, obesity and its impact extends kind of far beyond just medicine. Like we spend a lot on treating this condition, and probably more than most countries, unfortunately. So again, it's a bigger problem than I think people realize, and it has social determinants that impact it, but it also impacts social issues as well. So it's kind of a bidirectional relationship. Now, again, there are complications that we associate with obesity, ones that everyone kind of thinks of: hypertension, dyslipidemia, cardiovascular disease, diabetes. But there's even certain cancers, endometrial, breast cancers, colon cancers are associated with obesity. There's a higher risk of falls because of some of the changes in center of gravity. You've got a large penis or a large abdomen, kind of like the patients I treat, who are BMI of 50, very large individuals. Their center of gravity shifts, right? They have challenges sometimes maintaining upright. So there's a higher risk of falls in those populations. There's also a very high risk of non-alcoholic liver disease. You talk to most hepatologists or liver physicians, liver specialists. This is a growing concern that there's this liver disease, which is not related to alcoholism. It's related to fatty infiltrations in the liver. In fact, when patients go to get bariatric surgery, they are put on a liquid diet for about 2 weeks to shrink the size of the liver. Like it's a much bigger problem. I think people realize the impact of obesity on the liver. Gallbladder disease, sleep apnea, respiratory problems. Again, we'll get into some of these in the pulmonary unit, but osteoarthritis, low back pain, gynecological problems. A lot of the patients that I work with in our bariatric clinic, they have issues of infertility. They don't have regular periods, or they don't have any periods as well. So abnormal menses. So it's a much broader issue than I think people realize. And if you look at this plot here, right, these are some of the most common things that affect the healthcare system overall, and a lot of them have this strong connection to obesity. Now, I do want to dispel some things right from the jump, that the truth defies simplicity. Yes, obesity is harmful to your health. Like, let's get down the brass tacks here. There's no way to avoid it. Yes, many conditions that obese individuals experience could be improved if they lost some weight. Like that, there's no way to escape that either. And we'll get into some of the pathophysiology, right? This is just these are facts. However, we need to stop perpetuating this belief, right, that a lack of motivation, right, is the primary cause of obesity. And I can tell you, after working with this population now for the better part of, or I think the better part of about 6-7 years, motivation is a factor, right? And we'll get into some ways that we can help with motivation, right? And allowing patients to experience success. But it's a much less of a factor than I think many people realize. And we'll get into some of those a bit. There are societal factors. There are environmental factors. There are psychological factors that contribute to obesity, which may, in some respects, may be a much larger contributor than just self-determinism, right? You look at social forces, social determinants of health, like, what a system produces often reflects the system, right? There's a lot of disparities in our current healthcare landscape, and it would come as no surprise that we have a large problem with unhealthy individuals, right? With obesity, and we'll get into some of those social forces. We'll get into some of the other factors, but I really want you guys to think much more broader. Obesity it goes so much further beyond just individual choices and self-determinism or motivation. And I really like this quote here by Spencer Waldowski, a colleague of mine. You've probably seen memes of his. But this quote here: "Just put the fork down. Someone has no understanding of obesity." And honestly, this is a very succinct, quote, right, or reference point here. But it's actually a pretty apt description of just people's lack of understanding of what kind of contributes to obesity. So, genetic, epigenetic, and societal environmental factors. Some genetic factors, right? There are several genes that have identified as potential causes, and there's actually several genetic syndromes associated with obesity. Prader-Willi being a big one. The gene that gets probably the most attention is UCP1. I'll write that out here. UCP1, which is associated with which is expressed in brown adipose tissue, which is related to energy expenditure. We'll get more into that. We see a reduction in that, basically, in patients with obese, and a higher amount in those who are a little bit obese resistant. So we think maybe brown adipose tissue is thermogenic. It contributes to energy expenditure. We think maybe a lack of expression of that gene, as well as other ones, may contribute. Now, some people say the genetic contributions to obesity can be as high as 70%. That's kind of debated, but there are genetic contributions to it. What may be even more of a factor really are epigenetic. So epigenetic factors are things that impact our gene, or environmental exposures that impact our genes and can kind of pass on to the individual as well as downstream and affect their children, their offspring. So there was a famous Dutch famine where there was a lack of available food. The children of women who were pregnant during the famine have a higher risk for developing obesity, and we think it's because there was a gene, or an epigenetic change that affected genes in those kids, these offspring, to retain calories, right? So we think there's potentially, epigenetic contributors as well, and even exposures to obesogenic products during pregnancy, we think can affect the offspring. So again, there is, some genetic and epigenetic contributors as well. Impairments in executive function, so your abilities to self-regulate, your ability to engage in goal-oriented behaviors, which is crucial for weight loss. We're finding that those are often impaired, or impairments in those domains are common in patients with obesity. And in fact, Executive functions have been shown to predict mid-treatment weight loss, which is actually a pretty important marker for how successful a program is going to be. So if you have certain cognitive deficits, like that may also contribute to your inability to lose weight and your higher risk of developing obesity as well. And again, like we mentioned, there are certain syndromes like Prader-Willi syndrome, which is a kind of a big one especially in terms of self-regulation of caloric intake. They also have intellectual disabilities, so they're often related. Don't look at these things as silos. Again, think broadly. So your preferences for food and your eating habits and behaviors are developed in early childhood. Like if you've only really ever been exposed to unhealthy foods as a kid, that's gonna kind of be what you prefer to eat. You develop your preferences for food based on what you eat repeatedly at home. We're actually finding that your preferences for food may develop during breastfeeding because the mother intakes influences the flavor of the breast milk. And kids, again, like they're repeatedly exposed to those tastes, and they develop preference for certain foods. So we're actually been some interventions to address what the mother intakes during breastfeeding to affect dietary intake. It may even develop in utero. There's some great work looking at prenatal and postnatal, again, flavor learning. Like you learn your preferences for certain foods based on what you're exposed to. And parental eating behaviors strongly been shown to influence those of other kids. Like in many respects, eating is a behavior, right? Like, it's something that like you learn, right? And if your parents eat unhealthy, probably likely you're going to be eating unhealthy as well. And your activity habits, your participation in your engagement in sport, exercise, or activity also tend to develop in adolescence and childhood. So again, there's broader factors that may impact your likelihood to gain weight and likelihood to not engage in certain behaviors or engage in certain behaviors. We're actually finding even your social network, who you associate with, may contribute as well. A person's chances of becoming obese are increased by 57% if they had another friend become obese. There's a great study that looked at changes in obesity. I think the Framingham group over a period of 32 years when they found these changes, and 40% if their spouse became obese. Your peer groups, even as early as childhood, you tend to organize them around people with similar activity patterns, similar dietary patterns as well. And we tend to model our activity around our least fit friend, which is a wild social phenomenon. But again, there are broader factors than just your individual choices. We're social beings. There's going to be social forces that impact kind of everything that we do. And then getting into societal factors, higher rates of obesity observed in lower STS populations. That may be due to the financial burden, of certain healthy lifestyle interventions, activity and exercise being a big one. Being able to afford a gym. I've worked with patients in this population my entire career. Affording a gym may not be an option. There may not be a gym in their area. They have to travel to one, and they don't have a car, or if they're relying on public transit or public transportation, that's going to be a significant barrier. If it takes you an hour to get to a gym by bus, you're probably not going to go. Co-payments, or just lacking an understanding of exercise. No one exercises in your house. It's just, again, think broader. In certain communities, there's lower access to green recreational spaces, lower access to parks, pools, and places just to exercise for free. Team sports in childhood. Some of the strongest predictors of long-term participation in sport is participation as a youth. And if you, again, don't have these opportunities, we're finding that lower SES families or families in lower SES households or school districts, the kids there are less likely to participate in sports, maybe less options. School programs for physical education and health have been cut, as well as athletics. Usually the first things to be cut. Health literacy, especially low health literacy, is associated with obesity, especially in kids. Again, if you don't have the tools, right, to equip yourself to make decisions pertaining to your health, it should come as no surprise that people struggle with weight gain. And there's probably, the thing that I don't think people realize the most especially in people who get into class 3 obesity, right? We're talking about severe obesity. There's a strong association between adverse life experiences like childhood trauma, particularly sexual trauma, sexual abuse, and experience in childhood, and obesity and binge eating disorders. And to just unpack this a little bit, I work with this population often. 80% of my population getting bariatric surgery are women, and again, the population I work with, BMI over 50. And you ask a lot of questions, and just, you work with these populations often, and you find out that they either ate, or food was a comforting thing for them. They ate to kind of comfort themselves from the trauma they were exposed to, or, which is kind of really hard to kind of to take this information, but to make themselves less attractive to their abuser. And like, this is a very fairly common report. And again, if you're approaching an obese patient with this belief that it's their fault, right, or it's their choices that led them to this situation, you're ignoring accepted science. You're ignoring the years that we spend investigating and working with these populations. It's such a much broader factor than a broader condition that I think people really give it credit for. So again, understanding the social forces allows you to relate better to your patients, allows you to be a little bit more, really, you could be almost culturally competent or sensitive to your patients, and you might be able to relate a little bit better to them. And we'll get into some things that we can do to help patients with obesity. But I think having a solid understanding of what may contribute to it and what does not contribute to it is probably the most important part. So we'll end here, and then we'll get into the pathophysiology of obesity.